I welcome you to the Family Medicine 4th year teaching curriculum. I am Dr. Chamath Fernando from the Department of Family Medicine. So today's session is going to be on prescription writing. You would have already covered the aspects to consider when prescribing in your pharmacology lectures. So this is an extension, whereas you will be looking at the ways to prescribe, the act of prescription writing itself. And this is supposed to be conducted as a small group discussion, so I would encourage you to ask questions in the discussion section below on the Google Classroom. So the objectives we are going to cover is just to see what a prescription is, and then the indications to prescribe, moving on to factors to consider when you prescribe, the patient-related factors and the drug-related factors. Then the writing the prescription itself, and then the closure. How do you hand over the prescription to the patient and then bring your consultation to an end? So the aspects that you will be questioned on in your examinations would be writing the prescription, which could be a part of your OSPE or the Objective Structured Practical Examination, and the factors to consider when prescribing. So those are the aspects that you need to know thoroughly. Now, first, if we consider what a prescription is, it is a form of a communication between the prescriber and the dispenser. The dispenser is usually the pharmacist, but we also respect all the other alternative and complementary therapies. So even if an Ayurvedic physician writes a prescription and hands it over to an Ayurvedic dispensary, that might as well be a prescription. But is a prescription always necessary at the end of a consultation? Not really. You charge the patient, if you do at all, for your expertise. You are not charging for the drugs that you offer the patient. So it is totally up to you to decide whether prescribing medicines would be appropriate, or you can just do some reassurance, advise on some lifestyle modifications, and conclude the consultation. And is a prescription again always necessary for a patient to obtain drugs from a pharmacy? Again, not necessarily. The patient might ask for certain medicines from the pharmacist depending on the patient's symptoms. So some paracetamol, some cetirizine for a runny nose, the pharmacist is able to dispense over the counter. But there are certain tightly regulated medications which are not possible to dispense over the counter, which include the opioid drugs, benzodiazepines, steroids, antibiotics. I know there are violations of this, the legal aspect, but they are not recommended to be dispensed over the counter without a prescription. And now, moving on to the indications as to why we need to prescribe. So the first thing would be, what the patient is expecting from you is the symptomatic relief. So you have to address the symptoms, then only the patient will become happy. And then cure is another motive behind prescribing. Say the patient has a bacterial skin infection, and you apply a dressing and prescribe some oral antibiotics, and you get rid of the infection. So you can aim for cure in certain such acute illnesses. And on the other hand, there are certain illnesses that cannot be cured once and for all, such as the ongoing diseases such as diabetes, hypertension. You can control the severity of the hyperglycemia in diabetes or the level of blood pressure in hypertension. So you can control ongoing diseases like chronic conditions. And fourthly, another aspect is you prescribe a medicine to prevent a complication arising from a chronic disease. For instance, a patient with diabetes and hypertension is prescribed aspirin. So aspirin is not going to control diabetes, aspirin is not going to control high blood pressure, but it is going to prevent the patient from getting a second heart attack. This is a secondary prevention measure for a chronic disease. So to prevent complications arising from chronic morbidities. And a fifth indication would be prophylaxis, to prevent a disease primarily. Say a patient is exposed to a patient with chickenpox and you give a varicella immunization or even acyclovir orally to prevent the patient from getting the infection. So that prophylaxis becomes another aim. Another indication which is also important is to counter the adverse effects caused by certain drugs. For instance, you prescribe a non-steroidal anti-inflammatory drug such as diclofenac, and you also want to co-prescribe a proton pump inhibitor such as omeprazole to counter the adverse effects caused by the primarily prescribed drug. So these are the main indications as to why you should be prescribing. And besides these conventional reasons for prescribing, you also have other strategic reasons why you have to prescribe. One such instance is that the patient might be needed to prescribe a placebo. You explain the situation to the patient and say that you might not need medications, but this patient is not happy. So for strategic reasons, you prescribe a drug, maybe a vitamin, which is least harmful and least costly to the patient. Otherwise, the patient is not really happy. But you try to avoid that as much as possible. And another reason would be where you prescribe certain drugs. You cannot really call them drugs. They could be chemical entities which are still in the trial stage. For clinical trials, you only know the laboratory evidence and maybe the guinea pigs based evidence, the studies that have been conducted on rodents but not on human before. So you are trialing that drug on human beings, then you need to explain the full extent of the knowledge you have, the potential beneficial effects, the potential harmful effects, and then let the patient decide whether he wants to enroll for this clinical trial or not. So that is another instance where even you do not know whether the drug is really safe or not. And it must be taken as a written informed consent for your own safeguards. So those are the indications to prescribe. And then moving on to the factors you have to consider while prescribing, you have two major areas that you have to consider. One would be the patient-related factors and then the drug-related factors. So the patient-related factors, you can definitely go in the same sequence as you take a history from a patient. So you start with the patient's name, maybe. Does that have an implication on the drug you prescribe? Maybe. You can get an idea about the patient's ethnic or cultural background, which might affect what you prescribe. And then the patient's age. So if you can remember your illustrated textbook of pediatrics, it says a child is not a miniature adult. So say the child is just half the weight of that of an adult, you cannot definitely say half of the dose of a drug that you prescribe for an adult is going to be safe for a child. There are contraindications. For instance, tetracyclines are not recommended in the pediatric age group. So in that instance, the age matters. Under 12 years of age, you might have to consider whether you are going to prescribe a drug that is prescribed usually in adults. Then the patient's sex, is that going to matter? Not in all instances, but say there is this patient within the reproductive age group, a female patient, and she has intractable form of acne vulgaris or pimples, you need to treat it. You have tried all forms of mild medications, adapalene, benzoyl peroxide, and even tetracyclines. You have tried that, and you want to move to the next step where you prescribe retinoids or vitamin A, which is a known teratogen. So what do you want to know before you prescribe retinoids? You want to exclude pregnancy. You want to know for sure that the patient is not pregnant when you prescribe, regardless of the fact whether the patient is married or not. So you do maybe a pregnancy test to ensure that she is not currently pregnant, and you also want to advise the patient to use an effective contraceptive method for the duration that the patient takes the medicine and even beyond, because certain teratogenic effects might outlast the duration that the patient takes the medicine. So the sex really matters in such instances. Then moving on to the patient's presenting complaint, that is the main symptom that the patient is presenting to you with, and you want to address that to comfort the patient. Then the history of presenting complaint and the systemic inquiry. With that, you get to know more about the patient's condition, what other symptoms patient might have, other concerns the patient might have, and whether this presenting problem has affected any other organs, systems that, say, probably renal failure or liver failure that might affect your decision on prescribing certain medicines, and to decide on the dosage, whether dosage modulations are required. So systemic inquiry. And then you move on to the past medical history, where you assess whether the patient has other comorbidities or other illnesses associated with this problem, which might affect your decisions. And for those comorbidities, which drugs the patient is currently on, and which drugs, food, or whatever the patient is allergic to. So with these three segments, you are going to assess the drug comorbidity interactions, drug interactions, and drug host interactions. So you exclude all of that to ensure patient safety. And then you move on to another aspect, for instance, past surgical history. Do you think this really has implications? Yes, really it could. Say the patient has undergone an intracranial surgery 2 weeks back, and now the patient has developed deep vein thrombosis and with a possible pulmonary embolus, and you want to anticoagulate the patient. Then you have to be really cautious, because administration of such can cause further cerebral hemorrhages. So past surgical history is of value in that instance. Then family history, not routinely affecting your decisions, but say you are going to prescribe a simple drug such as a nitrofurantoin to a patient with urinary tract infection, and say the patient is a male patient with a father who had episodes of passing red urine when he consumes certain medicines or certain food items. So what is that pointing towards? Yes, it could be G6PD deficiency. So the familial history might also have implications on what you prescribe. And last but not least, there are so many aspects to consider in the patient's social history. If we elaborate on that, social history, you can ask about the patient's alcohol intake. How is that going to affect the medicines? Yes, alcohol itself can cause disulfiram-like reactions in the patients taking metronidazole. If you put the patient on metronidazole, it can cause devastating effects. So you have to take that into consideration. And alcohol can also affect the metabolism of certain drugs. Acute alcoholism causes inhibition of enzymes, which in turn increase the concentration of drugs in the blood circulation, whereas chronic alcoholism could lead to hepatic enzyme induction, leading to a reduction in the the drug concentration in the patient's bloodstream. Smoking, not routinely affecting your decisions, but again, say you are going to put a patient with chronic obstructive pulmonary disease on domiciliary oxygen. So you have to be cautious whether there is someone else, even someone else who is smoking in the same household, which could have disastrous effects. So the aspects of smoking. Then about the patient's educational level. If you prescribe a complex regimen of medicine, is the patient able to comprehend that? So that depends on the patient's educational level. And then the patient's occupation. The patient is a heavy vehicle driver and you want to prescribe an antihistamine for an allergy, and are you going to prescribe a sedative antihistamine as opposed to a non-sedative one? So that is where an occupation would come into play. And then the patient's income or the financial status, where you could see whether certain drugs are affordable to the patient or not. Even if you prescribe something that is not affordable to the patient, that is not going to work. And although you would assume that educational status would have implications on the patient's occupation, and in terms the income, that may not be the case necessarily. The patients who are educated might not have jobs and they might not have an adequate income to purchase the medicine. So don't make assumptions, but ask explicitly from the patient whether you are able to afford this medicine. You just ask that. And then the degree of family support the patient has, which also has a bearing on the compliance on the medicines. So these are the patient-related factors, and you may also identify certain risk factors in the phase where you examine the patient or order certain further investigations. So there is a lot to explore on what to prescribe when you decide based on the patient's factors. And now we will move on to the drug-related factors that you have to consider. So the drug-related factors would be, as you would have known from your previous pharmacology lectures, it could be pharmacokinetic or pharmacodynamic effects of the drugs, the ceiling effect, trough effects, oral bioavailability, especially for a patient with a short bowel maybe, and the half-life of a drug, and the possible adverse effects. So certain drugs have serious adverse effects, then you are very reluctant to prescribe that drug unless it is really necessary. And then besides this, you can also manipulate the answers that you have written for the patient factors to devise drug-related factors. For instance, the patient's income level is related to the affordability of the drug, or I would say the cost of the drug. If it is a very costly drug, might not going to work. The patient might not be able to take it. And then the availability. You don't prescribe all the medicines available on BNF unless it is available to purchase in the local context. Then we move on to a very important aspect, which is called the safety profile of a drug. If we move on a little bit further about the safety profile of a drug, so a safety profile is, say you have a patient who is 60 years old and has diabetes that has been recently diagnosed, and the patient has pre-existing hypertension and ischemic heart disease, and the patient is obese. Now you want to start a drug for the patient's diabetes which has just been recognized, and you have a multitude of treatment options for a patient diagnosed with diabetes, but you are going to be very selective on what you are going to prescribe. So how do you make that decision? You have insulin on one hand, but unless the patient is critically ill or the patient has very high blood sugar levels, you are not going to resort on insulin for possibly a type 2 diabetes patient. Then you go for oral anti-diabetic agents. And the options you have may be sulfonylureas like glipizide and gliclazide. Then you have biguanides such as metformin. Then you have thiazolidinediones like pioglitazone and maybe acarbose. And moving on, you have all these newer versions of drugs which include, you say, sitagliptin or exenatide or canagliflozin, empagliflozin. You have all these newer versions of drugs. But which drug are you going to decide that is going to suit this patient? Of course, you have all these new drugs of proven efficacy, but there is this old medicine that you have previous experience with, and there is a wealth of information about the drug, the beneficial effects, the rarest of side effects the drug might have. You have all the information about metformin, but not for these newer versions of drugs. And considering the patient's history, metformin would be the ideal medicine here. So that decision is made on the safety profile of metformin when compared to the other therapeutic options you have. So that is how you decide based on the safety profile. Now we move on to writing a prescription properly. So what form of a paper are you using for this? If you meet one of your relatives in a wedding, maybe you decide to write a prescription on an envelope, on paper serviette? No, that is not acceptable. So you have to use a decent paper, at least A5 size, which is half of an A4, to write your prescription. And it must be legible at all costs. So that is something that physicians are being criticized for. So come out of it. Make it, you have to correct it at some point. Now looking at the paper that you are going to prescribe, you might have a letterhead. That is best practice that you have a letterhead right at the top saying the institutional name, address, contact details, and maybe if you have website information, everything to be printed on top. And then moving on, it is very necessary that you put the date somewhere on the top, followed by the patient's details. Which patient's details are we concerned about? The patient's name, age, sex, where the patient is from, if that is really necessary, the clinic number. So these are the main aspects that you write on top. So this is something that you will be asked in your examination. And then I have seen like certain clinicians practice writing the diagnosis of the patient's condition right at the top. Especially for patients might be sensitive to having to disclose information about their conditions to outsiders. So this is not best practice for you to write the diagnosis on top of the prescription, but rather you can start by saying, start with recipe. This mark stands for recipe or else treatment that you are going to prescribe. Now you start with, and how do you set about writing information about one particular drug? For instance, you are going to prescribe diclofenac sodium, then the dosage form, then the frequency of administration, and for the said probably whatever the duration you prescribe it for. So the generic name of the drug, followed by the dosage, followed by the frequency of administration and the duration of administration. And there are variations. For instance, if you write diclofenac sodium 100 milligrams SOS once daily for 3 days, without stating the route of administration, this dosage form comes as a suppository. So you do not want the pharmacist to instruct the patient to take the suppository orally. So you don't want to do that. So what you do instead is you write, if this is oral, you write it oral. And if diclofenac sodium, if this is a suppository, you write it specifically before the generic name. And then moving on to the name of the drug, you have to necessarily write the generic name of the drug. But what about the trade name? Are you supposed to write it? Usually not. But in situations where the drug regulatory authorities of a country is not tightly regulating the number of brands entering the country in terms of their effectiveness and in terms of their cost, then you might have to write a trade name of a drug that is most effective and least costly for the benefit of the patient, not for your own benefit, but for the patient's benefit. In that instance, you are allowed to write the trade name of the drug after the generic name within brackets. But if all the drugs available in the market are equally effective and equally costly, then there is no point that you write the trade name there. Then the dosage form, of course. Then the frequency of administration. So this is one way of writing the frequency of administration. So if you go in this format, it would be once daily, twice daily, BD, 3 times daily, TDS, 4 times daily, QDS, and what if it is acyclovir, where you have to prescribe it 5 times daily? Is it FDS? No, you just write that 5 times daily. You write it in the fullest extent. So this is one form of writing the frequency. But for certain medications, it is necessary that you want to disperse the dosing along the length of a day. For instance, antibiotics, which are effective towards the antimicrobials in a concentration-dependent manner, or it kills through a time-dependent antimicrobial killing. So in that instance, you want to disperse the dosing throughout the day. So you want the patient to take, if it is once daily, you say 8 a.m. each day. If it is twice daily, you want the patient to take it 12 hours apart. If it is 3 times daily, 8 hours apart, 4 times daily, 6 hours apart, and in instances where you prescribe drugs like immediate release morphine, it could be 4 hourly, which is 6 times a day. And for certain drugs such as insulin, you might want to specify a time, and at a specific time the patient has to take different dosages of the same drug. Say soluble insulin, so if you say Mane, you take 10 units, at noon you take 12 units, and at night, Nocte, you take another 14 units. Or even there is another dosing time which is called Vesper, which is in the evening. That is the usual time that insulin is given, in the evening rather than in the night, to prevent hypoglycemic events in the night. So these are the manners that you can write the dosage forms. And as for the duration, you might say 3 days in this manner, or 1 week, 1 week, 1 month. So depending on your practice, that is really fine for you to even say 3 days, 1 week, or even this form is acceptable. Now, again, it is a good practice if you write the total number of tablets and circle it off at this point. So you want to, the patient takes the tablet 2 times daily for 3 days, which means the patient is taking 6 tablets altogether. So you circle it up there. And if we take another scenario, you are prescribing a drug to a patient with a long-standing condition. For instance, metformin for a patient with diabetes. And what is the duration? The patient is under good control, so you can see the patient in another 3 months' time. So you could write 3 months here, but the patient might not be able to afford the drugs sufficient for 3 months in one go. The patient might have to take it 1 month at a time. So in that instance, you can say for 1 month, and beneath you could write it the same prescription could be repeated for a further 2 months, up to a total of 3 months. So you can write it in your own words in the end, so that the patient can produce the same prescription to the pharmacist in the next 2 instances and get refills up to a total of 3 months. So that is another good practice to follow. Now we are going to look at a practical situation where you want to prescribe a medicine for a elderly woman who has been diagnosed with pharyngitis, and you have also identified with the modified center criteria that the patient most likely has a bacterial form of a sore throat, that you want to prescribe antibiotics. Then in the prescribing, you have to see whether the patient, certain sociological aspects of the patient. So for instance, you want to prescribe a macrolide. So the options you have would be erythromycin, clarithromycin, and azithromycin. So the usual dosage forms: 500 milligrams 6 hourly, clarithromycin maybe 250 milligrams 12 hourly, and azithromycin 500 milligrams once daily. So what are the differences? If you look at the side effect profile, erythromycin is the worst drug in terms of gastrointestinal disturbances and other adverse effects, followed by clarithromycin, and azithromycin has the greatest tolerability so far. And if you consider the pricing, even though erythromycin has to be taken 4 times a day, it is least costly than clarithromycin, and azithromycin is the most costly drug. And if you look at the dosing intervals, azithromycin has to be taken only once daily, whereas erythromycin is cumbersome to take with 4 times daily regimen. Then how do you decide? This elderly woman lives alone but draws an adequate pension to be able to purchase azithromycin. Then you might go for azithromycin because she lives alone. She might be able to take it once daily, but she might not be able to take it twice or 4 times a day. And there is another elderly lady who has family support. There is a granddaughter who is able to give the medicine to the grandmother in 6-hourly intervals. So she can set an alarm in her mobile phone and take the medicine 6-hourly. So the patient does not have a good income or a pension. So in that instance, you have to go for this cheapest drug, having explained the possible adverse effects. Now, if we ultimately have to resort for erythromycin 500 milligrams 6-hourly for say 4 days, then that is the only option available for you. The patient cannot afford, so you have resorted to prescribe erythromycin. But how possible is it for the patient to take it 6-hourly? Say there is someone who can set alarms, but if the patient takes the first dose at 8 a.m., the following dose will be at 2 p.m. and the next one at 8 p.m. and the last dose at 2 a.m. in the morning. So it is very likely that the patient might not take the last dose at 2 a.m. She might think, okay, I've taken 3 doses, that is good enough. But that is actually not good enough, in the sense the best way would be to take the medicine as dispersed as possible 4 times a day during the course of a day. So the strategy is, the good thing about elderly people is that they sleep less number of hours during the night. So one strategy would be ask for the patient's waking time, say 6 a.m., and the patient goes to sleep at 12 midnight. Then you take the initial and the last doses intended for a day at the waking time and at the time the patient is going to sleep. And the number of hours remaining in between the sleeping and waking times, you are going to divide it into 3, right? And you get the timings for the additional 2 doses. In this case, it would be 12 noon and 6 p.m. And it sounds all right. The patient can take 4 times daily regimen without a problem. And say the patient goes to sleep at 10 p.m. rather than 12 midnight, again, you divide the number of hours between 6 a.m. and 10 p.m. and divide it into 3 and explain to the patient how to take the medicines. So having explained all the necessary aspects about taking the medicine, you move on to the segment where you, right at the bottom of the prescription, you write your own details. So it has to be covered by your signature, your name, your designation, whatever, consultant family physician or whatsoever, and the qualifications. This may be embedded in your rubber stamp and your SLMC registration number. So these must be embedded in your rubber stamp or must be written at the bottom of the prescription. And looking at the future, this prescribing practice might be incorporated into the electronic health records, where it will be really easy for you to get all the patient's details will be their default on the sheet before you start to write the prescription itself. And if the patient is allergic to certain medicines that have been identified in previous consultations, that will pop up in a bright color on the computer, so that will be easier for you to spot certain allergies and cross allergies. And then if you go on to write the prescription, you can select the medicine, and through drop-down menus you can select the dosing regimens. So that will just come up and it will be printed on paper, so that you don't have to be writing in your illegible form of handwriting. So this is the act of writing a prescription, and there is more to it that we cannot cover during this session. And in the end, you are supposed to hand over the prescription, and there is more to it. You have to explain to the patient how to take each medicine. You have prescribed metformin to a newly diagnosed diabetic patient, and you say, okay, this white tablet, you have to take it after meals. That the relationship to meals, I couldn't mention that earlier. So certain drugs are better absorbed with food, and certain drugs are best absorbed on an empty stomach. So based on that, you can also describe what is the best time to take the medicine in relation to food, in relation to meals. So මේ සුදු පාට පෙත්ත දවසට 3 පාරක් කෑමෙන් පස්සේ ගන්න. So in the patient's native language, you explain everything about the drug. And the patient's compliance, whether the patient is going to comply with your instructions, really depend on the relationship that you have built with the patient. If the patient doesn't really trust you, he or she might not end up taking the medicine. Which is why if the patient goes to an illness episode to a specialist that the patient has not been knowing for a longer duration, say an ENT surgeon has prescribed a certain medicine to the patient comes back to you with the prescription, doctor, is it really necessary for me to take this medicine? Do you know about its side effects? I want to know more about the drug from you. That is because of the trustworthiness that you have created in the patient's mind. So it is really important to build that relationship with the patient. And so this gets our lecture to conclusion, but this was supposed to be a small group discussion where interactions has to be possible, but it is still possible if you could raise questions in the discussion forum created on Google Classroom related to this lecture. Thank you.